Yeah, it's very likely that this is a class effect. Now, keep in mind that uh, most agents we use in clinic um, do have an effect on the lungs, including interstitial lung disease. So not just this class of agents, i.e. the antibody drug conjugates, but all agents, as I said, we talked about a few of them. But particularly those antibody drug conjugates seem to have a higher risk of interstitial lung disease. And I'm thinking about another agent that's commonly used in clinic, primarily in breast cancer, and that's TDM1, where all grade pneumonitis were seen at an incidence rate up to, I'd say, between 8 and 10%. And more severe cases seen in about 2 to 3% of patients with TDM1, actually in some studies up to 6%. So TDM1, which again is another antibody drug conjugate, seemed to confer a very similar risk in patients with breast cancer in this case. Uh, so we see the same rates of pneumonitis and severe pneumonitis and ultimately ILD. So I do believe that's a class effect, and it's been seen consistently across this class of agents. Now, when I say a class effect, I'm talking about the higher incidence. But any agent, again, to emphasize the point, any agent that we use in clinic, whether cytotoxic or immune therapy agent, can also cause interstitial lung disease, so pneumonitis and interstitial lung disease, albeit at a lower rate than what we're seeing with these antibody drug conjugates. The identification of interstitial lung disease, can be tricky. Now we know with these antibody drug conjugates that the risk is high, so your red flags are raised high. But when you're talking about a drug like gemcitabine, irinotecan, nivolumab, pembrolizumab, well, I think the PD-1 inhibitors are a beast on their own because the community oncologist has wide experience with them, sometimes actually more than the academic oncologists, and they've seen the lung injury. But for those chemotherapy drugs, such as gemcitabine, irinotecan, doxorubicin, and others the like, the rate is incredibly small, and sometimes, the red flag is not raised as high. But what I would say is that the symptoms are very much the same. The patient, that doesn't necessarily have any baseline lung disease or significant lung metastases and comes with a dry cough, with dyspnea on exertion, and then when checked in clinic, the respiration rate is higher than expected, and then they're oxygenating a little bit lower than usual, that should raise the red flag that there is a risk. And then the patient would get a chest X-ray typically, where you can see some infiltrates, and that could lead to a CT scan. Occasionally, the chest X-ray, the chest X-ray has some low level of sensitivity and specificity. I mean, adequate enough to start with it. But if the patient is quite symptomatic and the chest X-ray looks completely fine, I would say then you would push for a CT scan at that point. If the patient shows then that evidence of pneumonitis progressing into ILD, then any level of lung injury, you should stop the agent immediately. So the patient should not get the drug any further. There's another particular class of agents that can cause this as well, and those are the tyrosine kinase inhibitors, such as erlotinib, a little bit at a higher rate, but again, primarily used in lung cancer, and that can explain some of that. But also, any other TKI can do the same. So overall, the presenting symptoms are mostly non-specific, but in some ways will lead then into further imaging. Like I said, patients with dyspnea, patients with a dry cough, with a high respiratory rate, low oxygenation. I mean, all these are hints that those patients may be having issues with pneumonitis.